Thanks, Quentin. It's always great to be back here. Thanks to the organizers for having me come and to talk. And the conversation for me this afternoon is going to be about extremely preterm babies and the edge of viability. I have no disclosures to make. And just a little bit of an overview for those of you who need it. It's basically a bunch of questions. I don't know that I've got a bunch of answers, but we'll talk about what I call, and we call in the neonatal world, ELGANS, extremely low gestational age newborns, which are those babies who sort of are at that edge that we would call the limit of viability, the point where we don't know potentially what we can do to help them to survive. We'll talk about, can we predict survival? We'll talk about self-fulfilling prophecies, which is very important when you consider this topic. We are very powerful as physicians. If we say something is true, we can make it true. What is viability will be discussed a little bit. When to initiate resuscitation, what is the gray zone for resuscitation? What do we tell parents? What do parents want to hear, I think probably even most importantly. And I think for young folks who are coming up in this field, I think maybe there's some really important lessons that we can learn from the current literature about that. So just overview of the problem of extreme prematurity. It's not huge in numbers, but there's a lot of extremely low gestational age newborns born around the country, 3.8 million or so births a year in the US. About 0.67% of them are less than 28 weeks. So pretty tiny babies, and that's about 26,000 babies a year in this country who are born at that size. The white versus the black rate is pretty staggering, huge disparity there, and we might postulate a number of reasons for that. The causes for preterm birth, especially extremely preterm birth, are variable. It's kind of a laundry list up there. And we've talked a lot about some of them this morning. Byron hit a lot of these in his discussion. I want you to note that I do have on there prior surgical abortion, and that's another topic that I think gives me a job. Women with prior surgical abortions, much higher risk for preterm birth, many more preterm babies, but that's not the topic that I'm going to be covering today, but just some references to sort of buttress what Brian Calhoun was talking about this morning. So nationally and internationally, where are we at as far as policies related to resuscitation of extremely preterm babies? And what you'll see up here is what typically has been done is look at survivals based on gestational age, and then policies that have been formulated by countries, by unions, by a variety of organizations about what you should do. So if you look at 22 weeks, and this is a systematic review of 34 national or international guidelines. At 22 weeks, comfort care is what's offered in the vast majority of these policies. There's some that say maybe you can individualize care, some with no recommendation, but that's pretty clear. Down at 25 weeks, it seems pretty clear that most folks say that you should be resuscitating at 25 weeks and intervening at that point. But there's still some outliers that is not the case. And then in the middle, at 23 to 24 weeks, we have a whole hodgepodge of different recommendations going on, depending on where you live. And that can be nationally. It can even be within the different states that you might live in. It might even be the hospital that you deliver in compared to the one down the street. So factors that are important in determining whether an extremely low gestational age baby can survive are listed up here. Everybody says gestational age. It's probably one of the most misleading factors that we discuss in relation to how well a baby can survive, and we'll talk about why in a second. But other factors that are important are the weight for gestational age. We know that small for gestational age babies do not survive as well as babies that are appropriately grown. Singleton babies do better than multiples, and this is all based on data from John Tyson published in the New England Journal back in 2008. Females do better. The males, as usual, are the weaker sex. Exposure to antenatal steroids is critical and important. Chorioamnionitis makes things a little bit worse for you to survive if you're an ELGAN. Where you're born is important. The volume of those types of births in the hospital where you're born are important. And then there's also other factors that influence this. So what official societies are saying, what hospital policies are, and what the willingness is of obstetricians or neonatologists is or are to start resuscitation. So, how sure are we about gestational age? Apart from IVF, where we sort of know exactly what gestational age might be, this is what the best stats are out there in sort of the error that's ingrained in gestational dating. So if you're looking at ultrasounds that are between 9 and 12 weeks, you might be plus or minus 5 days. If you're looking at 16 to 20 weeks, you might be plus or minus 10 days. And this has an edge on it as well. This could be like 3 days to 8 days, and this could be 8 days to 2 weeks even. So there's a fair bit of error built in there. The other thing that is prone to error is estimations of fetal weight. There may be as much as a plus minus 15% error in determining what fetal weight is. So for that reason, a couple of things strike me as I was putting this talk together. Strike me as things that are absolutely insane. So one, and we will do this commonly, not that I do it commonly, but people will try and do it commonly, is say, okay, we don't resuscitate for gestational age less than 23 weeks. Mom is 22 and 6/7 weeks. She will be 23 weeks tomorrow at 10 in the morning, so then we can come and resuscitate. Then we will give steroids, which, given the error that's built into gestational age, is really, it doesn't make sense. It's absurd. So the other thing that you should think about is if you're in a place that says they support 23-weekers, you should be really cognizant of the fact that actually, they're not all 23-weekers, and you're probably supporting 22-weekers that you think are 23-weekers. Also, if you're supporting 22-weekers, you probably are supporting some 21-weekers a fair bit of the time. So the gestational age is used as a be-all, end-all, but it's an absurd notion. So what else can we use to try and assess how a baby might do and whether a baby will survive? A lot of my friends will say, well, you know, we'll look at the baby in the delivery room. They'll tell the parents, we'll see how things go. We'll look at the baby. We'll assess the baby in the delivery room. If things look good, we'll keep things rolling. We'll keep the train moving. We are awful at assessing in the delivery room how well a baby is going to do. So you can see up here looking at babies who are survivors and who are non-survivors. Red is non-survivors, babies who die, and then the open circles are survivors. You can see at 1 minute and 5 minutes, depending on the APGARs, there's a huge splay of those scores. There's multiple studies that have shown this. What I'm showing you for studies are really examples of pretty good mountains of literature that are out there demonstrating these facts. So APGAR score, appearance in the delivery room, if you've got folks or you're an OB and you're working in a place where the neo tells you he can tell how the baby's going to do in the delivery room, I throw the flag, the BS flag, and say no, that does not work. The literature is clear, that doesn't work. I know you think it might work, but it doesn't work. So the attempt to sort of try and make all of this simple, this very complex problem simple based on gestational age is really inadequate. There's no value really to using the delivery room assessment to tell you how a baby's going to do. But there is one other device that has come along over the last 10 years or so that many people do use, and it's called the NICHD estimator. Has anyone ever heard of this? Do you use the estimator, those of you who are OBs? Do you call it an estimator? What do some people call it, Robin? The calculator, right. So the estimator is based on data from John Tyson, that second reference there, New England Journal article back in 2008. It's statistical data, it's population outcomes. But what people will default to repeatedly is looking at that as an estimator for how well a baby is going to do. Use it as a predictor for how well a baby might do. And really it just describes the range of outcomes that a baby might have. So the estimator is up here. So this is a still screenshot. The data that the estimator plugs in on the NICHD website, you give it a gestational age, your best estimate, by the way. Birth weight, your best estimate, by the way, but oh, you don't have a birth weight. So you got to put in your best estimate for a fetal weight. Okay. So that's not really the best estimate, but it's what we got. The sex, whether it's singleton or multiples, and then whether steroids were given or not. And then you hit a button, and what it spits out for you are these readings right here. So it's potential outcomes: survival, survival without profound neurodevelopmental impairment, and so on, death or profound neurodevelopmental impairment, and there you go. And these are two different kids, both 500 grams, both 23 weeks. This is a male over here. This is a female over here. This one over here has no steroids. This one over here got steroids. So this baby over here has everything going for them: steroids, female, singleton. This one, no steroids, it's a male. So the outcomes for kids that we resuscitate: survival 18%, survival 38%. Now, a couple of things to realize. This is old data from 2008, which is actually data that was collected for a earlier period than that. It was back into the early 90s, or 1990s into the early 2000s. The other thing that really troubles me about this is our propensity to do this, to equate death and survival with profound impairment. So that's something that I will come up to again as well in some discussions about what families think about all this. But what will often be presented are these numbers from the estimator to parents. And by the way, in a survey of 1,000 neonatologists published last year in Journal of Perinatology, 61% of neos use this estimator. I'm not sure how important it is in totally driving their decisions, but they use this estimator to counsel families. So where are we at for survival? So I try to pull up the best, most recent numbers, at least in big data sets that I could find for y'all. This was published back 2 years ago, Clinics of Perinatology, and this has got a couple of really good authors on here, including John Tyson, who we previously mentioned, but Ed Bell, whose name will come up again. Ed is a neonatologist in Iowa, and Iowa has really been on the forefront of trying to explore the territory of survival for extremely low gestational age newborns. And they have some really incredible numbers, actually, for the work that they've done. The numbers that you see here, 22 weeks, 23 weeks, 24, 25 weeks, different epochs. And I think what's important to see is starting out here at 25 weeks, we're kind of just bouncing around somewhere around 80%, which is where we've been since 1993 or so. But we've made great strides in the 23, 24-week babies. And these numbers go back through 2015. The numbers are even better. They're a little better out here for those gestational ages. The other thing that's different over time, especially as you look at the current NICHD database, which I could not put on this slide, we're seeing survivals at 22 weeks now. They're approaching 10%, and actually they're even a little bit higher than that, and we'll talk about some disparities where numbers are even higher than that for 22 weeks, higher than 20%. This is internationally what's going on. So this is a variety of different countries, data systems, includes France, Switzerland, the UK, Australia, the US, the pediatrics data set. Pediatrics owns about 400 NICUs across the country. Very extensive data warehouse with lots of information in there. The Canadian Neonatal Network, our network in the US, the Research Network, Sweden, the Express Network, and then Japan. And if you look at survivals for the varying gestations, you'll see at 25 weeks, people are generally sitting about, if they're doing well, 75 to 85%. But then you've got places down here that are much lower. And that sort of follows all the way down. And the fact is, there's less resuscitation certainly going on in France and Switzerland and the UK for these smaller babies. So if you're not resuscitating the babies, they're dying, so they're not surviving. So that's a piece of this. The other piece you might say is, if you don't have the experience of taking care of these extremely small babies, you may not be really doing it very well yet. So until you get that experience, you're going to struggle and have difficulty. This is Sweden, and this was published last year. and looking at their survivals for 26 weeks is blue, 25 weeks is orange, 24 weeks is gray, and then yellow is 23 weeks, and this is 22 weeks for Sweden. Sweden has made a huge effort to really try and explore where the borders of viability are and where the edge is for viability. So you can see here that they've got survivals for 22 weekers that are heading up almost towards 60%. And similarly, they've got really great survivals as well for the other small babies. So these are the trends over time. It's pretty clear over time there are lots of places doing a lot more for these small babies, but it's certainly not happening everywhere. So what we end up with generally when we're counseling families based on all this data, all these considerations, is some kind of monologue like this. So we go out to the room, we sit, and it's a mom with a 23-week baby. She comes in preterm labor. She's in the midst of labor very often, very emotional. Her significant other may or may not be there at that point yet, and we're trying to make life and death decisions and decide what does she want us to do and what should we do. If we only are offering comfort care, the baby's going to die. If we offer intervention, pretty widespread there, huh? Intervention, 0 to 70% survive, depending on your local stats. Okay, we'll talk more about that. But if you survive, you still might die. You might die in the delivery room, you might die in the NICU. If you survive, you're going to have a risk for a major disability, and those major disabilities include intraventricular hemorrhage, eye disease, retinopathy of prematurity, chronic lung disease, deafness, blindness, a host of issues. And then 1 in 3 may have a minor disability, hyperactivity, dyslexia, behavior, feeding problems. I think this category is pretty interesting to me, the minor disability. With a daughter who's 18 with autism and feeding problems, this is life-altering. So, I mean, we tend as neonatologists not to even think about these things, but these are huge issues which can really impact a family and are probably things we don't talk to families about in terms of preparing them for what life is like with a baby who might be this small and might have some disabilities. But this is sort of kind of what it looks like when you go in. It's an exchange of information. It's a heated moment. You oftentimes don't have much time with the mom. And then you basically are saying whether your cutoff is 23 weeks or 24 weeks or 22 weeks, what would you like us to do? Right. So we as neos are pretty sure that sometimes you parents, whoever you might be out there, just don't quite get it, you know? So we're trying to give you all this information because really all this counseling is about is information exchange. We got to give you numbers and make sure you get the numbers and understand what's going on. And we want to make sure that that happens. So how do we make that happen in a better way? Well, we come up with decision aids, all right? So these are actual decision aids used at some facilities to try and help that transfer of information with parents. And what you see up here are things like, well, here's your survival at 22 weeks. These little yellow babies are the ones who survive. All the ones that aren't yellow don't survive. You know, long term, all these green babies have disabilities, that kind of thing. Or we go over here and we talk about problems if your baby survives. And we even say, if your baby survives, 2 out of 3 may never be able to walk, talk, see, or hear, and a nice, cute little picture of a wheelchair. I mean, maybe that'll get the message across. Surely that's going to work. I mean, that'll get it done. And so it comes down to we want to transfer this boatload of information and have you make a decision. And by the way, we also bring our own biases to this decision. So we're trying maybe even to direct you towards a certain decision. So what is survival in the US? We saw those numbers, right? At 23 weeks, the numbers are between 0 and 70%. Think about that. I mean, where in medicine would we tolerate a survival for a common condition of 0 to 70%? So the range is here. It's published data. Kempf, up in Providence up in, on the West Coast. They only do comfort care at 23 weeks at Providence, so most of their babies die. Baton is kind of a middle-of-the-road place. They publish, they have 40% survival, and then I told you about Ed Bell. Ed Bell in Iowa is published, and they have 70% survivals for their 23-week babies. So there was a question someone asked me, what are survivals for some of these little kids? This is the issue. There's a huge range of survivals, and it really depends where you are. 22-week survivals. I'm going to show you the article, but the range for 22-week survivals, very small numbers. There aren't many 22-week babies that have been resuscitated and we have data on, but the range is 0 to 100%, depending on your facility. I mean, the 100% is a couple of babies. Our survival at our place for 22-weekers is 50%, but it's a very small number of kids that parents have said, yes, come to my delivery and resuscitate my baby. But the important thing is that parents do not know this generally. They do not know the range is 0 to 70%. They do not know if you're up in Providence and you have said we're not resuscitating babies, that across the state line there may be a place with 50% survivals. And why don't they know that? And shouldn't they know that? And they don't. So regional variation in practice also exists in this country. And this is just a diagram looking at the states broken out into regions. We've got 9 regions here. And if you look over here, we've got 22 weeks is this dark line here. 23 weeks is this dark line here. And this graph is showing you in each region of the US what neonatologists who were polled would say is the lowest gestational age that they would resuscitate at. So 22 weeks, there's some places that might say 20% of the folks polled would say, yeah, I would resuscitate that baby. But there's a few places where it's like 0, Division 1. Not totally shocking. And Division 9. Not totally shocking either, okay. And then, you gotta laugh or else we'd all be crying in here, so. So then, what about the oldest baby that you would not resuscitate? 24 weeks. There's like, 25 to 40% of folks are saying at 24 weeks, that's their limit. Above 24 weeks, they would absolutely, at 24 and above, they would resuscitate. Majority of folks saying at 25 weeks and above, they would resuscitate. So this as well is pretty variable. So depending where you're at, I mean, just to highlight the point, this is regional, this is by hospital, this is international, this kind of variation that's going on. Even in Sweden, so I talked about how well they are doing and really trying to explore the boundaries of viability and what they're doing in their country. They actually met back in 2016 and came up with some consensus guidelines for how to approach the extremely low gestational age newborns. So this was 22 and 23 weekers. And what they said was that all those moms should be transported to an ELGANS center that's experienced in the care of these babies, that you should consider giving steroids at 22 weeks if you're going to resuscitate, that a NEO should be a NEO, not a fellow, not a practitioner, a NEO should be any delivery from 22 to 23 weeks. And that CPR should be considered from 22 weeks to 23 weeks. And this was all in association with what the families wanted. It wasn't mandating they would do this necessarily for every baby. But what's important to see is they still have a lot of variation. All of these different lines here show the different units in Sweden, Stockholm, Uppsala, Lund, Göteborg, I mean, all the way across there. And you can see lots of variability here in these places with regard to when babies died at 0 to 12 hours, 0 to 365 days, or survivors. So lots of survivors here, much higher survival, lower survival here. So variation even in Sweden, where they have consensus guidelines. It's not mandated by the government, but this was agreed upon by all the key organizational medical groups across Sweden. So this study, I think, really is important for us to think about as neonatologists, certainly. So this was published in the New England Journal in 2015. It was a look across the NRN network, so the Neonatal Research Network, sponsored by the NICHD, looking at infants born between 2006 and 2011, all kids before 27 weeks of age. They had data for kids that were 22 weeks of gestation if they weighed more than 400 grams. NRN does not collect data on kids less than 400 grams, so they had what they had. So this was almost 5,000 babies at 24 hospitals, and 86% of them received active treatment. This is active treatment, so that included one or any combination of surfactant, intubation, TPN, epinephrine, or chest compressions. So that's pretty reasonable definition of interventions, not just a little blow-by oxygen or a little bit of CPAP. So what they found when they started looking at percentage of infants who received active treatment at 22 weeks, 23 weeks, 24 weeks, 25, and 26 weeks. At 26, 25, and even at 24, most of the babies in the network were getting active treatment. Things start falling off at 23 weeks. So you're down to about maybe 75% or so are getting active treatment. And then at 22 weeks, about 20% or so are getting active treatment. So there's some movement towards this group, but not nearly what we see up here. So it would seem that at least in the NRN, 24 weeks currently seems to be the point at which active intervention is a go. They didn't explicitly state that in the article, but that's what the data kind of sort of looks like there. And then if you look at the breakdown for infants who received active treatment at 22, 23, 22, 23, 24, 25 weeks, I'll just look at the lower end of the spectrum here. 22 weeks of gestation, survivals, overall for 22 weeks, 5% was the mean. The interquartile median was 3.4, so small numbers. But the range that you see over here is pretty high. So the mean for infants who received active treatment at 22 weeks and survived was 23%, and then 21%. But the range goes out on the mean to 34%, and the median is out to 50%. So there's some places with small numbers that are having very different survivals for these types of babies. And it really appears that it's driven, obviously, by their making interventions. The other places without interventions have survivals at 22 weeks of 5%. It's similar at 23 weeks. You see the same kind of trend. So I'm not going to walk you through all that, but it kind of makes sense. So the other issue that always comes up too, I said there's always this combo outcome of death or severe neurodevelopmental impairment, which I think is just horrific because they're not the same as the father of a daughter who's severely developmentally impaired. She ain't dead. But the developmental outcomes for these babies are probably not what a lot of people expect they are. So the long and short of this, and I'll show you a couple slides, really is that from 23, we don't have a lot of outcome data on 22-weekers, but from 23 to 25-weekers, the developmental outcomes, the impairments, are pretty similar across that spectrum. There isn't a whole lot of difference in terms of severity of their outcomes. So resuscitating, caring for, and keeping a 22-weeker alive does not guarantee that you're just going to have a horribly damaged kid compared to what a 24-weeker would be. And you can see this here. This is all centers in the NICHD network, looking at 3 epochs. And the epochs up here are 1, 2, 3. This is 2008 and 11, 2004 to 7, 2000 to 2003, looking at the individual hospitals and looking at percents. So this is percent of babies who died. Yellow is infants who survived with impairment. And orange is kids who survived without any neurodevelopmental impairment. And this is 22 to 24 weekers, okay? So without neurodevelopmental impairment, just look down the row, is anywhere from 13 up to 24%. No neurodevelopmental impairment. Even the yellow area has got neurodevelopmental impairment, but that can be ranges of neurodevelopmental impairment. So it could be mild, moderate, or severe. So I think some folks might be under the impression that all of these babies have severe, if they survive, severe neurodevelopmental impairment, and it's just not the case at all. Similarly, another slide, this is from Sweden, looking at their follow-up for their extremely low gestational age kids. And what you see up here is cognitive scores, language scores, and motor scores for completed weeks of pregnancy. Their numbers for this study, which was back in 2013, were too small to really say anything about 22-weekers per se, really low number. But 23, 24, and 25-weekers are all within the range of error for each other in terms of these scores. So, and that's what we've seen in the US too. There's several studies that have been produced at US institutions that show exactly the same. So the 23 to 25-week range, sure, they have developmental delays. Some of them are severe, yes. But it doesn't mean that a 22 or 23-weeker is necessarily a whole lot worse than what you might see with a 24 or 25-weeker. So in all this conversation, you saw that, I talked about a little bit, showed one slide where it seemed like 25 weeks was sort of the bar for people in terms of where they would say, hey, we need to be resuscitating babies at least 25 weeks. Has that bar really shifted over time? And this is looking at the UK, Sweden, and the Netherlands. 3 different countries over in Europe, looking at what they do at 22, 23, and 24 weeks, and it even includes 21 weeks. This is survey data. So you've got a baby born, good condition at birth. What happens? Percent of respondents who would be prepared to resuscitate. You don't start seeing people in the UK, and certainly not in the Netherlands, ready to start resuscitating until at least 22, maybe 23 weeks. But they really take off at like 23 to 24 weeks in the UK and the Netherlands. This is Sweden. Sweden totally takes off at 22 weeks, where they say they will go ahead and they're prepared to resuscitate. So a little bit different in lots of different places. This looking at a NICU in Chicago. So this is work that was done to try and assess over the last 2 decades. Where have we gone in the country in terms of looking at babies who are small, less than 26 weeks, so the 25-weekers and below? Survivals clearly have increased. The percent mortality has clearly dropped over time. But what about the decisions that are made in the delivery room? What happens? So I'm just going to focus on gestational age here. This is interesting too, but we'll run out of time. So gestational age in 1988, the smallest baby resuscitated, the square, was still like 23 to 24 weeks over this epoch through 2008. And the biggest baby not resuscitated was sort of in this range here, about 24 to 25 weeks and hadn't moved. So it looks like in practice, at least in a couple facilities, and this is not unique to this one hospital, there's one other study out there that shows this, some people are just pegged at this 25-week mark for where we would go ahead and intervene, absolutely. And then they're sitting with the lower mark being somewhere around 24, even back up towards 23 weeks. So have we reset the gray zone boundaries? I think in some ways we have, because survival has gotten better. So it's forcing people to think about it, but I don't think officially we reset any boundaries. So I think generally people still, if you surveyed folks, would say 25 weeks is sort of where we have to intervene and do things. And that generally, depending where you're at, it's 22 to 24 weeks is where people are going to say that's the smallest baby they would intervene for. That's despite the research that's out there. The equivalent outcomes for preemies that we've seen at 23 weeks, we don't have 22 weeks, show there really is no difference between 23 and 25 weekers. So that really should not be driving us. APGAR scores don't help. Reliance on appearance in the delivery room doesn't help. So what are we supposed to do? Some people raise the concern about the cost of care for these babies and say these kids are just too expensive. We shouldn't really be dabbling in this care for babies who are going to be severely injured and they're all going to die. We've established that's not the case, but we'll talk about cost here in a second as well. So what do policy statements say? This is a Reader's Digest version of the AAP policy over here. Basically, it says 22 weeks, no intervention, nobody survives. Not true. 23 to 24 weeks, according to parents. 25 weeks, yes, we have to resuscitate. But elsewhere in medicine, gray is gray. In the adult world, gray is gray. You don't have policy guidelines like this in the adult world for what to do with certain things, out of hospital arrests, that type of thing. But we're trying to make very simple rules for what are really quite complicated decisions. And I would say the OB criteria are similar. They're not a whole lot different. They don't encourage resuscitation down at these lower gestational ages. There's a lot of considers, which really leaves things wide open for practitioners to consider what they would like to do. So, are babies different than older patients? And I'm thinking some people think they are. If you have an out-of-hospital arrest with an adult, 10 to 50% survival with a 50% chance for an outcome without a disability. That's what you got on a good day. And we take that all day long. And we put these things, external defibrillators, everywhere. But when it comes to discussing what's going on with extremely low gestational age babies, the most fragile among us, people seem to think a little bit differently about those lives. So are those lives different? And there's some evidence that we do think differently about them. This is a survey that was sent out looking at a variety of different clinical anecdotes here that involved a 24-weeker, a term baby, 2-month-old, 7-year-old, all the way up through an 80-year-old. And I'm not going to go into the details of the anecdote, but this is physician providers and nurses responding to this pediatric survey done by Annie Janvier. And clearly the losers are the 24-weeker and the 80-year-old who had really unbelievably severe illness and who was dying. And everyone else in the middle, people feel differently about and would go ahead and they'd be willing to do interventions. What if families think about their kids? And I think that's what gets lost a lot in all of this with these policy statements and everything else. I mean, we tend to think about what we think and what do the families really want? Do we take the time to figure out what the families really want? And this is one study that looked at attitudes of parents and attitudes of healthcare providers towards extremely preterm infants. And they asked one question. I believe an attempt should be made to save all infants regardless of birth weight. So if you look at the answers up top there, parents, about 64% of the parents, and even the control parents, a significant number of them, said yes, that is true. We should be doing that. If you look at providers, physicians and nurses, only 6% of docs and nurses agreed with that statement. So what about the money? I mean, and it's important in this study, the reason that people gave for not wanting to do things is up here. What folks said, healthcare providers said it was unethical to save infants who would have severe disabilities because of the lifelong stress that it would impose, but socioeconomic circumstances. Then family should not be a factor, but they did say that the cost of this care would be a factor in their decision. So what about the cost? So this was a study done by Bill Meadow in Chicago. So if you look at cost for resuscitation of newborns, if you look at the little babies up top there for survivors and those who die, non-survivors are gray, and the percentage, so 75%, and this is extremely low gestational age babies in these birth weight categories, and their resource allocation, mainly meaning bed days in the unit, extremely low. When you look at adults and you look at the non-survivors and their use of bed days, extremely high in comparison. Really, the cost argument doesn't pan out for these babies. So that's something that can be reasonably dismissed. So there's no real good financial arguments to say that we shouldn't be taking care of these babies. If parents want to give their babies a chance, maybe the best thing to think about is at least a trial of intensive care with them. And you know what is most helpful is bringing them into the NICU and seeing what they will do. The trial of therapy is the most predictive sort of form of outcome predictor that we have for these kids, because we're no good in the delivery room, we're no good beforehand, the estimator is not that helpful, And it's really over the first several weeks of life. These extremely low gestational age babies now, babies like this used to die in the first several days, first week of life. That date has been pushed out. I mean, they now die on average, if you look at Vermont Oxford Network, our big neonatal network, about 14 to 21 days. So they're alive for a little while. 22-weekers, generally, if they're not going to survive, they will not survive within the first 4 to 5 days. So, but the trial of therapy may be the best way to go for parents who want something done. And we just have to consider what we're talking about when we talk about futility. Is it really quantitative futility we're talking about, which is physiologic, which is the baby can't survive, or is it qualitative? And then I think we have to decide what is the qualitative factors. Who decides? What are biases? And who makes a decision that some lives are worth living and some are not? Last thing I'll just mention a little bit is about parents and shared decision making. That is the battle cry now for medicine, teaching residents and fellows and all of us how to do shared decision making. That assumes, first of all, parents want to share decisions, which may not be the right thing. It is based heavily on information exchange, which we've talked about is not necessarily the right thing, and it doesn't necessarily address the concerns that families have. So is there an alternative method that we can think about in terms of trying to engage with families? And I think there is. I would think about this more as personalized decision making, because honestly, some parents want to make their own decision. Some parents want you to make the decision. No matter how hard you want to make it a shared decision, they want you to make the decision. And they can't say, I'm going to determine that today is the day my baby dies. So yes, we're ready today to take them off the ventilator. They are not capable of doing that. So in making personalized decisions, basic rules: understand the situation you're in, appreciate your own opinions, basic politeness. We shouldn't have to talk about this, but we do. You know, I think we all get caught up in busy worlds, and we're trying to do different things, and we forget some of these basic interaction rules for families. But go in and introduce yourself, who you are, who's with you. You only try and bring as many people as you have to. I understand a lot of us are trying to teach, but you know, these are very difficult circumstances for families at 3 in the morning when mom is laboring and about to deliver a 500-gram baby and dad's not there yet. Proper space to do this kind of conversation, usually it's at a mom's bedside. Sit on the mom's bedside. Ask for permission, but sit with the mom. Get below the mom. Do not stand above a parent ever when you're having a conversation like this with them. Know what the baby's name is. If you don't know it, ask the baby's name when you walk in the room. Personalize this conversation. And then you need to expect that there's going to be some silence when you're talking about this. You have to be comfortable standing there and letting nothing be said, and just take in the moment and see where it needs to go. For parents, you need to sort of try in that short conversation get a handle on what their decision-making style is. That's very, very important, and it's not easy. That's hard. You want to know what information they need. So they don't need maybe necessarily that little diagram with all the yellow and colored babies to say how many survive or not. They may say, doctor, just do your damn job. I want my baby. I understand what's going on with the development stuff. What will it be like when I try to take my baby home? And then emotionally, you need to understand what's going on with the families. We talked about a lot of this, so I'm not going to run through this again. But one thing that came up in a conversation, Annie Janvier, I've got references for her on here, she said one thing that comes up in talking with moms in preterm labor with the father in the room in multiple conversations, the fathers seem to be worried that the mom may not survive. I've never thought about that. But Annie talked to us about this last week at a state meeting we had, so I think that's important to think about. There are sheets that you can use for residents, house staff, and this is some of the work that Annie's published. You can get a hold of that. And then so, to close out, dying is not usually in an infant's best interest. Impairment is not death. Quality of life is in the eye of the beholder. Do everything or do nothing language should go away. Don't predict outcomes based on the delivery room assessment at all. Gestational age alone is not a helpful parameter if you're not considering the other elements. If you're going to resuscitate, if I'm coming to resuscitate, resuscitate. Don't do it half-assed. And go in there and do your job and get it done. And if the baby doesn't stabilize, baby doesn't stabilize. You bring the baby to the NICU, the train has left the station? No. Just because the train left doesn't mean you can't stop the train at some point. So recognize that. Arbitrary rules, bad news. They guarantee self-fulfilling prophecies, and statistics are statistics. The baby is not a statistic. That's it. So this is what we all work for. I mean, this day of discharge going home and that day in follow-up clinic when these kids come back. So thank you very much.